Today is very important topic, a sort of revision for you. The topic is vitamins. Fat soluble vitamins already covered by Dr. Jayashree Jadhav madam. So we concentrate today on fat soluble vitamins. Fat soluble vitamins, you know, there are 4 types of fat soluble vitamins are there. That is vitamin A, vitamin D, vitamin E and vitamin K. Out of that, vitamin A and D are very important from your exam point of view. Lots of questions can be asked in exam on these topics. I may say vitamin A, you may have a short note on xerophthalmia. Okay, you may have a short note on xerophthalmia, or you may have a brief answer question on vitamin A prophylaxis program in children. That may be a question, or they may ask you the question that is a treatment of vitamin A deficiency. That's all. So 2 marks question may be there for treatment of vitamin A deficiency. There may be a 2 mark brief answer question on prophylaxis, vitamin A prophylaxis in children. Up to 5 years we give vitamin A prophylaxis. Nowadays we give up to only 3 years vitamin A. So that schedule you must know. Then treatment of vitamin A deficiency and prophylaxis, both are required, and they both may be clubbed in one question or short answer. But usually a short answer question will be xerophthalmia. So mostly you will get a short answer question in our vitamin A. Vitamin D you may get a full question. Vitamin D you will get a full question. That is, they may ask metabolism of vitamin D at the first, or define rickets. What are the vitamin D, metabolism of vitamin D in the body, or effects of vitamin D on calcium metabolism, something like that they will ask. In the second they may break the question, and third may be the clinical features and treatment of rickets. So a full question may be asked on vitamin D, and usually you are restricted only to vitamin D deficiency rickets, nutritional rickets, and not the other types of rickets that is for postgraduate. So we will not go much detail about the vitamin D other than nutritional vitamin D deficiency. Vitamin E, hardly anybody asks the question, maybe some MCQ may be asked. That is premature babies. Vitamin E is important and may cause hemolytic anemia in premature babies. So usually we supply vitamin E to each and every premature baby. So MCQ may be asked on vitamin E. MCQ may be asked on vitamin K. Vitamin K, there may be MCQ, or there may be a brief answer question on hemorrhagic disease of newborn. So I think we'll try to cover most of this in this 1 hour lecture. Okay. So I will start with vitamins. I am Dr. Prashant Nikbekar, Professor of Pediatrics, Rural Medical College, Loni. Vitamins are usually called as micronutrients. What are micronutrients? Any nutrients whose requirement is less than 100 mg per day, they are called micronutrients. Anything above that are called macronutrients, like carbohydrates, proteins, fats, they are macronutrients. So vitamins are micronutrients, they are required in very small quantity in milligram or microgram. Okay. Fetus and infant usually get from mother first 6 months in the after infancy up to 6 months, because child is fed exclusively on breastfeed. So from mother breast milk, infant get up to 6 months. But after 6 months, usually if the complementary feeds are not started, then the breast milk is inadequate after 6 months. So child may develop vitamin deficiencies. Okay. Most of vitamins are not synthesized in the body. Just remember, most of the vitamins, they are to be supplied from outside, except vitamin D and K. Okay, vitamin D is synthesized in the body by help of sunlight, and vitamin K by the microorganism in the gut. It's very important, you must know. Only way, so MCQ may be asked on this. MCQ may be asked on this. What are the vitamins which are synthesized in the body? Then we give option 1, 2, 3, 4. So you must know it is the vitamin D and vitamin K are synthesized in the body. Okay, next we'll come to deficiency. Deficiency, why deficiency occurs in vitamins? Deficiency occurs maybe in decreased intake, maybe nutritional cause, poverty, socio-economic low conditions, ignorance, or there may be breast milk of the mother may be lacking in vitamin D. So baby may be getting good amount of breast milk, but the breast milk don't contain adequate amount of vitamin D, vitamin K. Vitamin C also not a very good source of, breast milk is not a very good source of vitamin C. So this may be the cause of deficiency. There may be increased requirement of the vitamins during infancy. You can see the infancy and neonatal period a rapid growth. The 3 kg baby becomes 9 kg at 1 year. So this is a rapid growth of the first year of the life, requires increased requirement of the vitamins. There may be third cause may be diminished absorption. There may be so many absorptions, fat soluble vitamins are not absorbed because there is a malabsorption syndrome, liver disorders where there is deficiency of bile salt, bile pigments, so the fat soluble vitamins are not absorbed. One fish tapeworm is there, Diphyllobrothium latum, that causes vitamin B12 deficiency. MCQ may be asked on this. Which is the tapeworm which causes vitamin B12 deficiency in children or in humans? So these are Diphyllobrothium latum or a fish tapeworm. So you must know these few important things. Now everybody knows this classification. From first MBBS you are knowing this classification, so I will not go in details of this. But on the left side you can see fat soluble vitamins A, D, E, K require bile salt and bile pigments for the absorption. They are not excess vitamin A and D. If they are taken in a high quantity, they are stored in the body. They may go to brain, bones, and they can cause different problems in the baby. So remember, the fat soluble vitamins should be given in very restricted manner and not a, okay. Most of these fat soluble vitamins are stored in liver. Okay. Now we come to water soluble vitamins. One thing is they are easily absorbed. They don't require any fat or any bile salt bile pigments. So liver involvement or malabsorption syndrome usually don't cause deficiency of these vitamins. They are excreted in urine. So you can see vitamins stored in the body. So they have to be taken day to day in a day to day manner. Except vitamin B12. Remember, you can ask all the fat soluble vitamins are not stored in the body except, so you must know vitamin B12 is stored in the body. Okay. All other vitamins are not stored in the body, B complex, they have to take day to day basis. Okay. So this MCQ is for you, except vitamin B12, they are not stored in the body in liver. Okay. Now we go to one by one different vitamins. I will first important vitamin is vitamin A, that is also called retinol. Retinol is a very important vitamin. It is used not only you remember it vitamin A for vision. No, it is not like that. Vitamin A is useful for vision, but it has other benefits also. Respiratory tract, any epithelium is there, vitamin A is required because for rapid proliferation, where they are there, vitamin A is required. So any respiratory tract infection, any organ which is lined by the epithelium, you require vitamin A for its functioning. Okay, so don't remember only vitamin A is for vision. No. So when you go to what are the different sources of vitamin, it is carotene, is a very important plant source. If you take large amount of papaya or mangoes, you may become yellow. Okay, but there is no toxicity. Very important thing. Even if you look yellow, you don't have toxicity. That is a very funny thing about this vitamin. So that is called carotenemia. Carotenemia is a condition where the baby become yellow. We thought it may be jaundice, but child has taken excessive papaya or pigmented fruits. So that also may be a cause. Then animal source, retinol is an animal source. It is alcohol. Retinol is alcohol, which is the animal source of vitamin A. So whatever animals we are taking, eggs, milk, then meat, chicken, everything will contain vitamin A. Also the cod liver oil, fish liver oil is a very important source of vitamin A and vitamin D. Okay. Now you can see the 60 grams of milligrams of retinol gives 2 lakhs of vitamin A. And somebody MCQ may be asked how many milligrams of retinol give rise to 2 lakhs of vitamin A, but not very commonly asked question. Right. So as I was telling you, vision and functional retina is important cause of this vision. But everywhere epithelium is there, vitamin A will have a role. Okay. So this is also called anti-infective vitamin. Why? It prevents the infection where there is epithelium. Now you know where is the epithelium? It is lining whole GI tract, it is lining whole urinary tract, it is lining whole genitourinary system, it is lining whole respiratory tract, eyes. So everywhere epithelium is there, vitamin A deficiency will affect that part of the body. Spermatogenesis, integrity of vaginal epithelium. If the deficiency of vitamin A, vagina becomes dry, spermatogenesis will be hampered. So that may be a reason for infertility in older age group. Okay, youngs. Okay. Also beta carotene, which is anti-infective property, antioxidant property, and antioxidants are very important to prevent infection. Okay. Therefore, vitamin A deficiency is there. Humans may get lung, breast, bladder cancer. So remember, these are the conditions they may occur if in the absence of vitamin A. So don't think that vitamin A only required for your vision. So it is called anti-infective vitamin. Okay. Now everybody knows this source of vitamin A. It is cod liver oil, short liver oil, liver, butter, yolk, red palm oil. Red palm oil is a very important source of vitamin A. Carrots, green leafy vegetables, any pigmented fruits like ripe mangoes, leafy vegetable, carrots, is a very good source of vitamin A. Golden rice, which is a genetically engineered rice now available, which is already has genetically, its color is also golden and it contains vitamin A. So if you consume that rice, automatically you will get vitamin A without no need of taking additional vitamin A. So it is a fortified, not a fortified, but genetically engineered. Okay. Now RDA is very important. You must know few RDAs, at least vitamin A, vitamin D, you must know. What are the recommended daily amounts? So it is very easy to remember. Yes, 300, 600 and 320 to 400 micro infants, children 400 to 600, adolescents 750. So around 300 to 800 is the requirement of the vitamin A. Okay. Now we come to what is VAD. VAD is a vitamin A deficiency. The short form is VAD. VAD is the commonest vitamin deficiency. So MCQ may be asked to you, which is the commonest vitamin deficiency? A, D, E, K or whatever it may be. So vitamin A deficiency is commonest vitamin deficiency in children. Okay. Also it is a common cause of preventable blindness. Very important. I will show you in the later slides how vitamin A deficiency can lead to blindness. It's a preventable cause. That's why we are supplementing all the children up to 3 years vitamin A every 6 months. Okay. Then if it is a vitamin deficiency subclinical, you will get recurrent respiratory tract infection, urinary tract infection, GI tract infection and affect reproductive function. So when an epithelium is there, there is a chance of infection or deficiency and there is a problem of these organs. Okay. What is the earliest feature of vitamin deficiency? Nyctalopia. You may get an MCQ, which is the earliest feature of vitamin deficiency. Nyctalopia also called night blindness. So this MCQ may be asking you, which is the earliest features of vitamin A deficiency. There will be 4 options and you have to write nyctalopia or night blindness. Okay, why the night blindness occur? Concentrate on this visual cycle. This is rhodopsin is a visual pigment. Blood, vitamin A, liver, from liver, vitamin A comes in the blood, it goes to liver and or retina, and here it is converted as active gradient, it goes to retina, and in place of opsin it causes rhodopsin, which is the visual purple. So also visual purple, or this is a visual protein, rhodopsin. So what happens now? Suppose you see at this rhodopsin there in the retina, light is produced, light is put is on the retina, and this rhodopsin is bleaches and light reaches the rhodopsin and it is converted into, opsin is removed from this and trans-retinal, which is the inactive products. Inactive products it produces, and this opsin causes, this bleaching reaction causes electromagnetic reaction and you get a vision. Okay, so rhodopsin is very important in the rods, it is there in the rods and cones, and rhodopsin once bleaches, it opsin is removed and there is the electromagnetic and you will get a vision. And this trans-retinal inactive goes against for blood to liver, and again a fresh cis-retinal active comes to the retina, and here it is cis-retinal is attached to the opsin and converted to rhodopsin. So important is opsin is available locally, but the cis-retinal active is never produced locally. It has to go to blood, liver, and then converted into cis-actin retinas. That's why we get night blindness. So this procedure is delayed. So continuous supply of vitamin A is required from liver in the blood to form this active cis-retinal. So I always say that God should have given the local conversion of trans-retinal to cis-retinal, then this problem might not have occurred. Okay. So, that this God should have given us this reaction, chemical reaction, that trans-retinal inactive should have converted into cis-retinal active directly in the retina only. No need of going to again to liver and converting to vitamin A and coming to in the blood again as a cis-retinal active. So this is my perception about this mistake by God, that this should have been done here only. Okay, then this problem would not have occurred. Okay, but now we know that this problem is there, so we have to supply. Vitamin A is continuous supply is required. So vitamin A should have adequate amount of vitamin A to continuous supply of the vitamin A active form for the vision. That is why there is a delayed vision in the night, and that is called night blindness. So there is delayed adaptation for the light in children, okay, or in adults also. Now everybody knows this xerophthalmia syndrome. You may have a short note on xerophthalmia. Okay, so you can write a rhodopsin cycle and you can write this primary signs and secondary signs. Everybody knows these primary signs: X1A, X1B, X2, X3 and X3B. They are primary signs. X1A is congenital xerosis. Okay, I will come to later on, but I will show the pictures. Secondary signs are XN is night blindness, XM is fundal changes. So there is sclerosis of the fundus. That is called FX. And there may be a corneal scarring. So this is XS. So there are secondary signs, but the primary signs we go to the picture. Okay. Now you can see this picture. Extremely on the right side, left side, you can see a X1A. That is conjunctiva. Only the conjunctiva has become dry. The cornea is still shiny, bright shining cornea. So it is X1A. B for B. Remember, beta spot is X1B. B for B. I always ask test student to remember like this. Beta spot is X1B. Why? B is beta spot. B for B. So you can see this beta spot on the temporal side of the conjunctiva on the bulb, and you can see this hip-like shiny silvery triangular structure, that is called beta spot, which is very classical of vitamin A deficiency. Then comes the corneal dryness and xerosis of the cornea. Xerosis means dryness. Then comes the dryness of the cornea. Afterwards, when the deficiency is still there, the child will go into a third stage, that is X3A, where there is the keratomalacia, the liquefaction of the cornea, and there is central perforation of the cornea, but it is less than 1/3. Of this cornea, if it is the perforation only in the less than 1/3, then it is called X3A. But the perforation more than 1/3, then you see this eye has almost the lens has come out of this corneal perforation. So this is X3B. These are two very bad situations. At least this is a treatable, but one child goes into X3B is very difficult, and now you can see this excess. Here both the corneas have become scarring is there and the child is totally blind. Okay, so this is a very preventable blindness, and if we had treated this child early, this child would have saved by his vision would have been saved. But now what happened? Where he has to go for only keratoplasty for his vision. Okay. Other features of vitamin A are skin, that is skin become dry, that is called toad skin. Respiratory tract, there may be recurrent respiratory infection. Renal calculi are thin because of the vitamin deficiency. Sterility because the spermatogenesis is hampered. And heterospermia is a very rare feature of vitamin A deficiency. We will not go into details of that. Okay, factor absorption in vitamin A status, decreased absorption in diarrhea, worm infestation, malabsorption syndrome, increased requirement in measles. Yes, measles will cause respiratory tract damage, GI tract damage. So epithelium is all the epithelium is destroyed in measles. So the requirement of the regeneration of epithelium, large amount of vitamin is required, and we should require large amount of vitamin A. Protein and the malnutrition, as per other vitamins, is also less. And preterm babies, usually the vitamin A are stored in the last trimester in the liver of the baby, full-term baby. So preterm baby which is born early has less amount of stores of vitamin A. So all preterm babies we give supplement this with vitamin A. Okay. Now this is a very important chart. Everybody knows this. When you see a child with vitamin A deficiency showing xerophthalmia, immediately on the first day we are seen in OPD, immediately give him, depend upon age of the child, less than 6 months you give 50,000 units, 6 months to 1 year you give 1 lakh unit, and more than 1 year you give 2 lakhs unit. And this again call the child next day for the similar amount, and then call the child after 2 to 4 weeks for the third dose. So total 3 doses are given in vitamin A deficiency when there is xerophthalmia. You must remember this chart by heart. Anytime if you are awakened from the sleep, you must be able to utter this chart. Okay. Now I want to telling you the prevention of vitamin D, that is prophylaxis. So now we have got vitamin A prophylaxis program in the children. All children or infants should receive 1 lakh unit at 9 months. So usually by vitamin A we give at 9 months along with measles vaccine. So no need to call the child repeatedly all the time. When child comes for measles vaccine, we give him. Nowadays not measles vaccine, nowadays we give MR vaccine or MMR vaccine at 9 months along with measles, along with MMR or MR vaccine, followed by 2 lakhs at 18 months. For booster he comes at 18 months, give again 2 lakhs. At 24 months, at age of his second birthday, give more 2 lakhs more, then at 30 and 36 months, 2.5 years and 3 years. So total 5 doses we give for children for prophylaxis of vitamin A. Then also child suffering from vitamin A measles. If child suffering from vitamin measles, any child coming to, this is a dictum nowadays, any child admitted to with measles should receive 2 doses of vitamin A on 2 consecutive days. Now there is little change. Initially used to give only 1 dose. Now there is a change. Any child suffering from measles give 2 doses of vitamin A on first and second day. Okay. There is also severe PM. Also any child coming with severe PM, instead of 1 dose we give 2 doses of vitamin A. Then consumption of vitamin A rich foods, fortified sugar. Sugar is also fortified with vitamin A, and golden rice. Okay. Now we come to vitamin D. Vitamin D is nothing but a hormone. Vitamin D is a hormone. It is not a, though it is classified as vitamin, most of the vitamins are amines, isn't it? Proteins. But this is a steroid. This is a steroid nucleus. You can see this steroid nucleus. Everybody knows this nucleus. So this is called a basic steroid nucleus, and vitamin D is a steroid. And also it is called hormone. Why it is called hormone? What is a speciality of hormone? It produces somewhere and acts somewhere. This is called hormone, isn't it? So vitamin is deficiency severely. It is produced under the skin, stored under the liver, and where it acts? It acts on GIT, kidneys, and also in the skin. So remember, vitamin D is called hormone, also called hormone. Vitamin D is a pentagonal structure. You must know this basic steroid nucleus, and it is a steroid. So it is synthesized from cholesterol. Remember, vitamin D is synthesized from cholesterol in the body. So I'll go to the vitamin D one by one. Yes, vitamin D is a chemically are steroid compounds. So what are vitamins? Vitamins, many vitamin D compounds are there. Yes, ergastol, cholecalciferol, 125 dihydroxycholesterol, that is active form. Calcitriol is also called calcitriol. So you must know all the forms of vitamin D. You may act MCQ on which is the active form of vitamin D. So it is a calcitriol. Vitamin is a calcitriol, 25 dihydroxy 125 dihydroxy cholecalciferol or calcitriol, which is the active part. Because ergastol, cholecalciferol are the active part. Vitamin D, what we say usually is the cholecalciferol, which is not the active part of vitamin D. Active form of vitamin D is produced in kidney and it is in the circulation, and this acts on bone, liver and kidney. Not liver, bone, intestine and kidney. Remember, bone, intestine and kidney. So this is very important, vitamin D. Now we can go to D3, not abundantly available. One more thing is that infants are more susceptible. I told you already, breast milk of some mothers will be deficiency in vitamin D. So this infancy only they will show the signs of vitamin D deficiency. So this is very important cause of vitamin deficiency in our India. Mothers are deficient. Mother's milk is deficient in vitamin D, and is the only good source of vitamin D for 6 months. So we have to supplement it from outside if it is not properly present in the mother, or you have to supplement the mother with vitamin D so she could have more amount of vitamin D in vitamin D rich breast milk. Okay. Then liver disease, kidney disease and malabsorption. Why these diseases should cause vitamin deficiency? Yes, liver. If liver is diseased, cirrhosis or any other chronic hepatitis, what will happen? Vitamin D will not be converted into 25 dihydroxy. The hydroxylation occurs. After the vitamin D is formed under the skin, it goes hydroxylation at liver and kidney. First hydroxylation occurs in liver. 25 hydroxy, 25 OH or 25 hydroxy cholecalciferol, which occurs in liver. If this is not there, liver is not functioning properly, this hydroxylation will not occur. The second hydroxylation occurs in kidney. That is, it is second time, that is 125 dihydroxy cholecalciferol. That is the active form of vitamin D which will not be produced in the kidney. So any child with chronic renal failure, multicystic kidney disease, or a shrunken kidney, so many kidney disorders will cause. Any child with chronic renal failure will not produce the active form of vitamin D. Okay. Malabsorption, I told you already, in the liver disorder is the fat soluble vitamin. So any condition which causes liver disorder will have less amount of bile salt and bile pigment, and vitamin deficiency will not be there. Any malabsorption syndrome will cause malabsorption other vitamins as like vitamin A, D and other complex vitamins. Similar will be there in the so malabsorption usually get all types of vitamin deficiencies. Okay. Drug like phenytoin. Why phenytoin should cause? You may get a question in exam. Phenytoin. Sometimes a simple question. So how phenytoin cause vitamin D deficiency? So it prevents the hydroxylation in liver. Remember, phenytoin drug which prevent the hydroxylation of liver in the 25 hydroxylase is prevented. That enzyme which is suppressed by phenytoin. Phenytoin is an anti-epileptic drug, and this anti-epileptic drug prevent the hydroxylation in the liver. So active form of vitamin D will not be formed. So this is the reason why phenytoin causes vitamin D deficiency. Okay. Now everybody knows this chart. Everybody knows physiological how the vitamin D is formed. Now just see dietary source. How will you get vitamin D? Dietary sources directly we get vitamin D from diet. But under the skin there is 7-dehydrocholesterol, or it is also called ergosterol. So this is converted into vitamin D by ultraviolet rays. Everybody knows this. Okay. Now this vitamin D is formed. This is called cholecalciferol. Everybody must know all these terminologies. Okay. So this is the cholecalciferol that is converted into liver by hydroxylation. 25 hydroxylase is the enzyme which converts this into 25 hydroxy vitamin D3. Okay. Then this form of vitamin D goes to kidney, and there is one more hydroxylation occurs, 125 hydroxylase, and is converted into 125 dihydroxycholecalciferol, that is vitamin D3, also it is known as calcitriol. Calcitriol. This is active form of vitamin D, and this active form of vitamin D acts on bone, acts on kidney, and acts on intestine to absorb calcium and phosphorus from intestine and kidneys, and also it helps in mineralization of the bone. Okay, so you may get a pathophysiology. How it is pathophysiology of the vitamin D? You must know pathophysiology of rickets, why it occurs. Okay, so this diagram is very important. This step, this flow chart is very important for you. Sources everybody knows: fish, liver, egg, but mostly non-veg foods are rich in vitamin D. Ultraviolet rays. So any infants usually why occur vitamin deficiency? They are not exposed to sun. They are kept inside the house. Their mother deficiency may be there in breast milk, so they develop infants. So this is our infancy. Rickets is our infancy because it is a growing bone. Rickets is a disturbed growing bone. So whenever the growing fast bone growth occurs during first 2 to 3 years, isn't it? So we get vitamin deficiency. Recommend daily allowance, very easy, 20, 200 and 400, double. Infants is 200, children is 400. So it is very easy to remember. Effect of vitamin deficiency, that I was talking about the pathophysiology. So decrease amount of calcium from the gut, because the active form vitamin D will help in increase absorption. So vitamin deficiency there, the calcium will be absorbed less from the gut. One thing. There is increase in the parathormone levels, and they will release the calcium from the bone. So again there will be deficiency of the calcium, demineralization of the bone. Reduce excretion of calcium and reduce reabsorption of fat. So reabsorption of phosphorus will be defective, it will reduce, and so normal bone formation will not be there, because formation of bone, both calcium and phosphorus are required. Okay, so body try to maintain calcium, phosphorus till even if there is vitamin deficiency by increased absorption of calcium, reduce excretion, but one stage comes when there is a calcium also becomes less and phosphorus also become less. Okay, and because of the deficiency of vitamin D, there is a defective mineralization of bone. Bone become spongy, or the bone become fragile, and they can get easily fractured, and they can become bowing of leg will be there. So problem with the soft bone. So bones should be soft in the rickets. Okay. Now this is today important topic, rickets. What is rickets? If you ask to define rickets, how will you define ricket? Ricket can be defined as defective proliferation, degeneration and calcification of bone. So all these three are present, then only the good bone will be formed. So there should be good proliferation of the bone cells. There should be a osteoblastic activity, osteoclastic activity. So bone is a dynamic process. Bone has a dynamic process is going on. Dynamic process is going on in the bone. There is a proliferation of bone. There is a osteoblastic activity. Osteoblastic activity. So in osteoblastic activity, there is a formation of new bone. So proliferation of the bone is there. Then to get the shape of the bone, and there is also osteoclastic activity. So bone grows in a particular manner because there is osteoclastic activity. Osteoclast will be there, osteoblast will be there. So this osteoclastic activity also will be decreased. And important thing is mineralization, which gives support, which is cementing. The bone, calcium of bone is called cementing. The cementing of the bone also will be defective, and you can get a defective calcification, and bone becomes soft and less rigid, and they will easy to going to alter their shape, become bowing will be there, and also there will be fractures. Okay. So this is called rickets is a disease of growing bone. You can get a full question on rickets. So you must know the rickets by heart. Rickets is a disease of growing bone. So usually up to 4 to 5 years you get a disease, but mostly by 6 months to 3 years is a period for getting rickets. Okay. Now what happens in problem of rickets? Mineralization will be poor, but osteoid will continue to expand. Osteoid function will be continuous. So there will be bone will be formed, but which is not less rigid and soft. Okay. The shaft of the bone softens and easily deform and become fractured also. And because the pressure, child is walking or crawling, there will be pressure on the wrist joint, metaphysis of the wrist joint, ulna and radius, or there may be pressure on the malleolus, lower limb. So when child so during the crawling stage, below 1 year usually we get the changes in the wrist joint, and older children you get changes also in the malleolus, because the children, and bowing of the legs will be there because when the child start crawling, okay, or child start walking, right? That's why with the pressure symptom, the metaphysis end become widened. I will show you the pictures now, few pictures of rickets. Now clinical picture, a MCQ, not MCQ, a brief answer question or not, or MCQ, short answer, SAQ. SAQ may be asked only on clinical pictures of ricket, a short answer question. So you start with the head to toe. You have to start with head to toe for all clinical features of the rickets. Now in general, first we think of general symptoms. What will happen in general symptoms? There will be failure to thrive. So child, first important thing, the deficiency initial will be there is a failure to thrive. And child has poor weight gain and poor height gain. Okay. And there will be hypotonia. All the limbs, muscles of the limbs become flabby. So there will be hypotonia and normal tone of the muscle will be lost. So muscle will be more lax, and there will be protuberant abdomen because the abdomen muscle also become hypotonic. Okay. Then we start with the head to toe. Important first is head will be I can say craniotape means. What is craniotape is? Craniotypical sensation of the skull bone. Okay. When you press, I'll show you what is craniotape is. Usually in the infants and newborn and preterm, you can get this craniotape. What happens craniotape is you press on the parietal bone here, and normally you can press it inside, and if you release it, it comes with a crack. That is a ping pong ball sensation. So you get a ping pong ball. You must have seen that ping pong or tennis ball. You press it and release it, there is a sudden click and you get a ping pong ball sensation. So this is very classically seen in preterm and normal infants and newborn and preterm babies. But in the rickets of older age baby, when the bones are firm, you will not see this sign. This sign is seen only in rickets when skull bones also become soft. And when you can ask in the exam, what is craniotapes? Question may be asked in exam, what is craniotapes? You have to demonstrate craniotapes. So you have to know this craniotape is, that is pressing the skull to get a little bit of ping pong ball sensation. Then anterofrontal is very large. In rickets, anterofrontal, because there is no much mineralization, anterofrontal remains large. Bursting of the skull, the frontal bone become a bursting of skull, and you can see this very classically described. Hot crossbone appearance. You must have known this pav bhaji pav. How they are looking like there is center ridge will be there, and there will be elevation of the other bones. So this is frontal bone, parietal bones. Usually they are elevated, and there will be ridges in between. So this is called bursting of the skull because of the expansion of the skull wall. This is why this occurs, because of expansion of the skull walls. Okay. So this is classically called as. This is classically called as hot cross bone appearance. Okay. Hot cross bone appearance. Sorry. It is hanged. The computer is hanged. Okay, there is a problem with the computer. Okay. Okay, we'll continue with this only. You can see these craniotapes. Yes, You can see the kinetapes, hot cross bone appearance. Then there is the chest, you can say rickety rosary. Then we come downwards, we can see the rickety rosary. I will show you the photograph of rickety rosary. There is a beading of the costochondral junction. There is beading of the costochondral junction. Okay. Okay, not going, coming. Okay. Some. Okay. Okay. So we'll start. We'll come down from head. We come to chest. Chest will show rickety rosary. Harrison groove. So there is a soft part where the insertion of diaphragm is there. That muscles are soft. So diaphragm will pull this intercostal muscle, and there will be a groove in the lower intercostal spaces. That is called Harrison groove. I will show you this picture also. This is all because of the Harrison groove is because of the hypotonia of the intercostal muscles, and diaphragm will pull this at the insertion of the diaphragm, and you will get a groove or ridge on the intercostal space, lower intercostal space. The recurrent infections, because the hypotonia of the respiratory muscles, definitely there will be recurrent respiratory tract infection. Okay. Then we come to back. There will be kyphoscoliosis, S-shaped vertebrae, kyphosis. There is the fundal of the kyphosis of the vertebral column, and there will be lumbar lordosis. All these things can occur in the children. Okay. Now we come extremities. What happened to extremities? Wrist and ankles will be widened. There may be valgus or varus deformity. If the knee joint touch each other, it is called valgus deformity. If knee joints and because of bending outwards, it is called varus deformity. I am sure the also all the photographs also. Now very important is because of the vitamin D deficiency, absorption of calcium will be raised and will develop hypocalcemia. So though it is very late, this is hypocalcemia occur late in the very advanced rickets, you get here signs of hypocalcemia. But you must know what are signs of or symptoms of important. So advanced rickets you get stridor due to laryngeal spasm. So it is very common. Advanced rickets, not very initial stage of rickets, you will not see this hypocalcemia symptom. But in late, when the body cannot compensate for calcium, then you get the symptoms of hypocalcemia. Okay. Now you can see this few pictures. This is the widening of the bowing of the leg. This is called bowing of the leg, and there is a genu varum. There increase the gap between both knee joints. The bones, long bones become soft, and they try to bend, and this gives a genu varum. Okay. Now you can see this child is a very full-blown picture of vitamin deficiency. You can see every in this child. You can see every deficiency. Signs of vitamin deficiency. Okay, you can see this rickety rosary, you can see intercostal. This you can very nicely you can see the intercostal beading of the at the costochondral junction. This is rickety rosary. You may get question rickety rosary in the exam. They may ask what is the difference between rickety rosary and scorbutic rosary. You must know the difference between rickety rosary and scorbutic rosary. How the scorbutic rosary occurs in vitamin C deficiency, or that is also called scurvy. Okay. Also you can see this protuberant abdomen, sometimes umbilical hernia will be there, protuberant abdomen will be there, and sometimes there will be umbilical hernia also. You can see the wrist joints which is widened. The wrist joints are widened, and there is splaying of the bones. This is because of splaying of the widening of the bone, there will be wrist joint will be increased in the size of the wrist joint. You can see the genu valgum. You can see this genu valgum, the knock knee, also called knock knee. Genu valgum is also called knock knee. Okay. So all signs of rickets and frontal wasting is there. So all signs of rickets are you can see in this child. Okay. Now very classical is a very bad case of rickets where there is a rickety rosary, and you can see this Harrison circus. As I have told you, this is the area where diaphragm is inserted, intercostal muscles under this. So these ribs are pulled inside with every breath, and because of the soft intercostal muscles and softened rib, diaphragm push this rib inside, and slowly over a period of time you will get a Harrison groove. Okay. Invasion is not very important in the clinical diagnosis. Vitamin D nutrient rickets is a clinical diagnosis, but we may have low serum calcium or normal. Phosphorus is always low. That is important. Phosphorus low. Alkaline phosphorus very high. Why? The increased osteoblastic activity in the bone. So osteoblastic activity causes increased alkaline phosphate. Urine calcium is low because body try to conserve urine calcium, and urine excess of urine calcium will be low, and urine phosphorus, because calcium is absorbed, phosphorus is excreted. So there is a high urine phosphorus in the urine. Okay. This is very classical radiology picture of rickets. This is on left side you can see this normal X-ray of the child of rejoin with radiation ulna and 1 or 2 carpal bones. Now you can see classical cupping, fraying and splaying. Splaying is widening, cupping means cupping like also the epiphysis is little, the diaphysis is little convex, isn't it? Now you can see this concave metaphysis. This is metaphysis, this is epiphysis, this is epiphysis, this is metaphysis and this is diaphysis. So metaphysis changes are usually occurring in rickets, and you can see this is a cupping, splaying means widening, and splaying, just it is cut like a comb. You can see, must have seen the comb, like that you can see this is called fraying. So these 3 words you must know. As a undergraduate you must know these 3 words: cupping, fraying and splaying. Splaying is widening. And you can see this number of carpal bones also decrease in the number. Usually if as should have 3 or 4 carpal bones, you will see only 1 or 2 carpal bones. So these are the clinical features. Always the slide is kept in the exam. Rickets slide is always kept in the exam for your table viva. So you must know these features. This will be covered again in Excel also. No need to go for refractory rickets, not for you. No need for vitamin C also for you at this stage. Now last 2 slides, vitamin E and vitamin K. Vitamin E is a antioxidant. Vitamin E is an antioxidant. Also it protects the membrane. It is phospholipid, so it protects the membrane of the cell. In preterm it has very low stores. So usually in children they develop hemolytic anemia or intraventricular hemorrhage. So remember, capillary stability also is because of vitamin E, and deficiency may lead to hemolytic anemia and intraventricular hemorrhage. The capillaries may break, and in children, in premature infant, they can cause hemolytic anemia. It is very important. It protects vitamin ROP, retinopathy of prematurity. Yes, retinopathy of prematurity is prevented by vitamin E. So usually all preterm we supplement vitamin E in all children. In the cholestasis, in the liver disorder, you can get decreased absorption of vitamin E because it is a fat soluble vitamin. Preterm usually we give for 6 weeks 15 to 25 units of vitamin A daily. This is a dictum. In all preterm babies we can give them vitamin E. Okay. Last slide is of vitamin K. Vitamin K, everybody knows, it is a useful for functioning of the vitamin and coagulation factor, synthesis of 2, 7, 9, 10. You must know this. 2, 7, 9, 10 coagulation factors are vitamin K required for their synthesis, and if this vitamin K absence is there or vitamin K deficiency is there, 2, 7, 9, 10 factors are not formed, and child will develop hemorrhagic tendencies or bleeding in the gut or on the bones. Anywhere bleeding can occur. I already told you synthesis occurs in the gut flora. I already told you synthesis of vitamin K occurs in gut flora. So if the less amount of gut flora or organisms are there, child will likely to get vitamin deficiency, K deficiency. This usually occurs in newborn child. Why newborn get vitamin K deficiency and hemorrhage of newborn? Usually on the 3 to 7 days. This is called classical hemorrhage of newborn. 3 to 7 days. Usually this period, on 3rd day to 7th day, the child bleeds. Child may have epistaxis, child may have GI bleeding, vomiting, hematemesis, child may have umbilical bleeding, child may have melena. So all this child can occur in the 3rd to 7th day. This is our classical vitamin K deficiency or classical vitamin K hemorrhage of newborn. Okay. So what we do all newborns. We will give vitamin 1 milligram vitamin K at birth to prevent hemorrhages of newborn. Okay. So by this we finish the fat soluble vitamins, water soluble vitamins already covered. So almost we are at the end of completing your theory lectures. On Monday we may think of a short stature. Once only few years back there was a full question on short stature in children. So we may have a lecture on short stature. We'll decide 1 or 2 days. So almost we are finishing your lectures, and few 1 or 2 neonatal topics are remaining. Let's see. Okay. So thank you very much, and stay home, stay safe. Okay. And do read vitamin A and all fat soluble vitamins. Out of that, vitamin A and vitamin D are very important from your point of view. Thank you. Good night. Good day. ये PowerPoint